Okay, so this will be part 3 of our neonatal and infant review questions. A 4-month-old baby girl is in your care for pallor and difficulty feeding for the past 2 months. She was born at 39 weeks and 5 days of gestation via uncomplicated spontaneous vaginal delivery. Physical exam is remarkable for moderate pallor, hypertelorism, and a snubbed nose. Labs are significant for a hemoglobin of 9 grams per deciliter. Hematocrit is 27.2, MCV is 105, white blood cell count is 5.3, platelets 388, reticulocytes are low, smear shows a macrocytic anemia. Further labs are ordered. ADA is elevated, folate and B12 are normal, parvo B19 PCR is negative. Bone marrow biopsy reveals decreased red blood cell precursors. Chromosomes are stable in mitomycin C. Which of the following is the most likely diagnosis? A. Fanconi's anemia. B. Transient erythroblastopenia of childhood. C. Diamond-Blackfan anemia. D. Pure red blood cell aplasia. Or E. Shwachman-Diamond syndrome. Okay, and give you time to pause it. And the answer to this one is C, Diamond-Blackfan anemia. So this is an extensive workup, but you should be aware of what Diamond-Blackfan anemia is in comparison to something that is very similar to it, and that is Fanconi's anemia. They both present the same way to a certain extent. However, there's one major finding that is going to be different, and that is that the chromosomes in Fanconi's anemia are not stable in mitomycin C or DEB. And in Diamond-Blackfan anemia, the chromosomes are stable in mitomycin C. So let's start from the beginning. We have a baby that was born pretty much at term, uncomplicated delivery, and when you look at the baby, she appears anemic, and she's also got a couple other findings that will play into the diagnosis. But let's just look at that anemia. So she's got an anemia. She's 9 grams per deciliter, so we know that's abnormal. Babies this age usually run around 10 to 14 hemoglobin. Her hematocrit is low as well. Her MCV is high. Usually MCV in babies is a little bit lower than it is for adults. In 4-month-old, probably see about 70 to 90, just because they have a little bit less hemoglobin than adults do. And then her white count is normal, if not a little bit low, 5.3, and her platelets are in the normal range. So we have a macrocytic anemia, and we have a moderate leukopenia. The reticulocytes are low, and that's a big deal because that tells you that there is a disorder of production. So we're not producing enough red blood cells. And so at that point, we are concerned about a possible issue with the bone marrow. The smear shows macrocytic anemia as we would expect, so further labs are then ordered. ADA is elevated, folate and B12 are normal. You should certainly rule that out anytime you have a macrocytic anemia. And then parvo B19 PCR is negative. Remember what parvo B19 causes? It causes pure red blood cell aplasia. So since that's negative, we can rule that out. We now get a bone marrow biopsy, and that shows decreased red blood cell precursors. Aha, that's why reticulocytes are low. So now at this point, our diagnosis is down to Fanconi's anemia and Diamond-Blackfan anemia. And what we do is we take the chromosomes and we put them in mitomycin C or DEB, DEB, and we see if they're stable or not, essentially. And if they are stable, it's Diamond-Blackfan anemia. If they are not, it's Fanconi's anemia. Diamond-Blackfan anemia tends to have aphases, hypertelorism, and this snubbed nose, sort of anteriorly rotated nose where the nares are kind of prominent. And so that can point you in this direction as well. Transient erythroblastopenia of childhood tends to happen a little bit later, and it goes away on its own, whereas this is more concerning. Kind of already talked about this. So this is also called congenital hypoblastic anemia, but Diamond-Blackfan anemia is a better way to refer to it because really you could refer to Fanconi's anemia in the same way, and this typically arises during early infancy. So the anemic symptoms become apparent at about 2 to 6 months of age. You can also see congenital deformities with this, which can include hypertelorism, snub nose, and malformations of the thumb. When you do your workup, of course, anytime you have a baby that appears anemic, you should get a CBC. That will show a macrocytic anemia. There also can be neutropenia or thrombocytosis, but there doesn't have to be. The reticulocyte count will be inappropriately low, and that reflects that we have a disorder of production rather than blood loss. The ADA is elevated, and this is useful in differentiating this from transient erythroblastopenia of childhood. Folate and B12 levels are usually normal. Parvo B19 PCR is normal. That differentiates it from pure red blood cell aplasia. And then the bone marrow biopsy shows decreased red blood cell precursors and a normal chromosome stability in either DEB or mitomycin C. We'll treat this by referring to pediatric hematology. Corticosteroids are typically given, but hematologists are usually reluctant to give corticosteroids until the baby hits about 1 year of age. Until then, red blood cell transfusions are usually necessary. The target is to keep the hemoglobin above 9 grams per deciliter. And important to remember that with Diamond-Blackfan anemia, there is a future risk of osteosarcoma. Question 17, a 2-month-old presents with his mother for a well-child visit. There are presently no complaints. Baby was born at 39 weeks 5 days via spontaneous vaginal delivery, weighing 7 pounds 4 ounces. Neonatal course was normal. Physical exam is unremarkable. Baby's breastfeeding. He currently weighs 11 pounds 3 ounces. Since this is her first time breastfeeding, the mother asks you if you have any advice regarding feeding. Which of the following is the most appropriate advice for this mother? A. Iron supplementation, 1 milligram per kilogram, should begin at 4 months of age. B. Cow's milk may be introduced at 6 months of age. C. Fortified cereals may be introduced now. D. Baby should be weaned off breast milk by 1 year of age. Or E. Baby should drink at least 8 fluid ounces of water per day starting at 6 months of age. So this is kind of common. You're going to see a lot more normal than abnormal if you're dealing with pediatrics. You get a lot of well-child visits, and so you're going to have to answer a lot of these questions. All right, so the answer to this one is A, iron supplementation at 4 months. So breast milk is not very rich in iron. It's got a lot of wonderful things in it. It's superior to formula, but it doesn't have a lot of iron. And so what needs to happen is we need to give iron supplement to babies who are breastfeeding. Now, babies who are on formula, they also need iron too, but the iron is included in their formula that they'll start at 4 months of age, so it's kind of already built in. So at 4 months of age, iron supplementation needs to be given. 1 milligram per kilogram is enough for a term baby. However, a baby who's premature will require more. They'll require twice that, 2 milligrams per kilogram. What about these wrong answers? So cow's milk should not be introduced until 1 year of age. The reason is because of cow's milk enteropathy, and that can cause bleeding and bloating and all sorts of nasty symptoms. So we do not give cow's milk until 1 year of age. Fortified cereals typically are not introduced at 2 months of age. Generally, that's going to happen at 4 to 6 months of age. As for the baby being weaned off breast milk by 1 year of age, it's really up to the mother when they stop breastfeeding. There is no indication for stopping breastfeeding at 1 year of age or even 2 years of age or really even ever. It's really just up to the mom. But breast milk is totally fine at 1 year of age. You don't need to stop. And then as far as the baby drinking water, babies should not be drinking water. Water is empty calories, and it's just going to make the baby less likely to feed. Really, children don't need to really start drinking water until they're up and running and sweating, and when you need water to replenish your fluid balance. Certainly not at 6 months of age is just free water necessary. You're getting fluid in your nutrition, so as long as the baby's on milk, they're getting enough water. Once they start eating hamburger and adult food, then you can start giving water to supplement dry foods. So vitamin and mineral supplementation is important to know for well children. Vitamin D is going to be started 400 international units per day during the first 2 months of life, unless they're on a vitamin D fortified formula. Iron should be given 1 milligram per kilogram per day beginning at 4 months of age per the AAP. Like I said, 2 milligrams per kilogram per day if they're preterm, unless they're on an iron fortified formula. Fluoride should be given starting at 6 months of age. A lot of times a pediatric dentist will do fluoride therapy for babies. Vitamin K should be given, and that's routinely given at birth. And then folate should be given if the baby's on goat milk. Now, we don't recommend goat milk as to be ever given, but in some cultural practices, they do give goat's milk. And so if they must, we recommend supplemental folate. A classic vignette is a baby who's on goat's milk and is not getting extra folate. And in that case, you will tend to have an anemia, macrocytic anemia, which we would expect with folate deficiency. So you would see a baby with pallor, anemia, failure to thrive, possibly glossitis and stomatitis, and then they're found to have an elevated MCV and possibly electrolyte abnormalities. So really, goat's milk and especially cow's milk are really bad ideas for babies. Cow's milk should always be avoided. Goat's milk should be avoided if possible. If not possible, give folate. Question 18. A primigravida mother delivers a term baby boy at 9 pounds 5 ounces. Pregnancy was complicated by hyperemesis and gestational diabetes. Second stage of labor lasted 12 hours. APGAR scores were 5 and 8 at 1 and 5 minutes. Cyanosis resolved with nasal CPAP. On physical examination, you note green staining of the nail beds, coarse breath sounds. Heart, respiratory rate, and muscle tone are all normal. Chest x-ray reveals irregular infiltrates. Which of the following should be performed at this time? A. Tracheal suction, B. Intubation, C. Surfactant administration, D. IV antibiotics, or E. Insertion of umbilical artery catheter. All right, the answer to this one is E, insertion of umbilical artery catheter. So it's somewhat clear what this baby has. Baby is having respiratory distress, and you note green staining of the nail beds, in addition to a rather difficult labor, which can cause distress. And so this is probably meconium aspiration syndrome, especially with the green staining of the nail beds. I could have said that there was meconium in the show, but that would have made this too easy. So the first thing you ask yourself when you have meconium in the show or a baby stained with meconium is, or when there's respiratory distress in general, is the heart rate, respiratory rate, and muscle tone normal? If it is, in the setting of meconium aspiration syndrome, you do not need to do tracheal suction. Just suction out their nose and their mouth. If it's not, then you should do tracheal suction and intubate the baby. So considering that the heart rate, respiratory rate, and muscle tone are normal, we don't need to do tracheal suction and intubation. We certainly don't need to do surfactant administration. That's done for preterm babies that have respiratory distress syndrome. IV antibiotics are not indicated for meconium aspiration syndrome. You do want to insert an umbilical artery catheter to ensure that their blood gases are normal. And we do the umbilical artery catheter because this is just easier than poking the baby over and over and over again. So meconium aspiration syndrome is aspiration of amniotic fluid containing meconium, which is usually passed due to significant fetal distress or post-term. The symptoms are exactly what we saw here: coarse breath sounds, meconium in the show, meconium stain on the baby. They can have a barrel chest appearance. Diagnosis is chest x-ray as well as the clinical presentation. Chest x-ray shows irregular infiltrates. That stands in contrast to respiratory distress syndrome. uh, where you don't have the where you've got generalized collapsing and atelectasis, and that's where you don't have any surfactant. It's in preterm babies. That's generalized infiltrate. Um, in this case, you have irregular infiltrates. The treatment is neonatal resuscitation based on status on delivery, suction the trachea if the baby is bradycardic, has poor respiratory effort, or has poor muscle tones. Otherwise, you don't need to suction the trachea. At that point, then you'll just do positive pressure ventilation and careful monitoring. And you want to do the umbilical artery catheter to monitor the ABGs. This is typically going to require them to be admitted to the NICU. You'll also want to monitor their hemoglobin and oxygenate them to keep it over 13 grams per deciliter. You'll consult neonatology for further care. Here's an example of a chest x-ray in Meconium aspiration syndrome. Note the irregular infiltrates. As compared to respiratory distress syndrome, where you pretty much just have whiteout. Question 19. A 6-month-old presents with her mother complaining of difficulty feeding and pallor. Mother says she thinks she first noticed it a month ago and it's been slowly getting worse. Pregnancy, labor, delivery, and neonatal course were all normal, and baby's been well up until now. On further questioning, mother tells you she breastfeeds and supplements with cow's milk, which she said her sister-in-law told her to do to, quote, help the immune system, unquote. Physical examination is remarkable for pallor. CBC reveals a hemoglobin of 8.4, hematocrit of 29.1, MCV of 67. Which of the following is the best next step in the management of this patient? A, packed red blood cell transfusion. B, dietary advice and iron supplementation. C, peripheral blood smear. D, bone marrow aspiration. Or E, iron supplementation. All right, and the answer to this one is B, dietary advice and iron supplementation. So you have a baby who's been getting cow's milk. Remember I said don't do cow's milk. Bad idea. And this is cow's milk enterocolitis, or enteropathy. So what happens when you give cow's milk is you get inflammation in the intestine and you get bleeding. And that bleeding ultimately will cause anemia. Now it's very slow bleeding, so typically parents aren't going to notice anything in the stool. And so because this is so insidious, it will slowly get worse, and then suddenly it will get bad enough to where a parent will notice that the baby is anemic, is pale, the baby's not really active, will have difficulty feeding because the baby's lethargic. And so in this case, you want to know about the feeding history, and cow's milk is a dead giveaway. So because the baby, yes, is anemic, but we know the cause, all we need to do is tell mom not to give cow's milk anymore. Auntie was wrong. And give iron supplementation, and the baby will respond really well to that. Okay, so you don't need to replace the red blood cells because there hasn't been a blood loss. The baby doesn't have any other symptoms other than pallor, and we know that if the cow's milk stops and we give the baby iron, the hemoglobin will go back up. So we don't need to do any kind of transfusion. Now, I would say if this baby was down like 6, then yeah, maybe do transfusion. But 8.4 isn't tremendously low, considering that, especially since this has been such a slow blood loss, babies have probably adapted to it. But all you really need to do is make sure that the cow's milk goes, and then give iron supplementation to help with the building of new hemoglobin. Since we know the cause, we don't need to do any of these other workups. So cow's milk enterocolitis, also known as cow's milk protein-induced enteropathy syndrome. Cow's milk should never be given to children under 1 year of age. Also, we should never give children under the age of 1 honey. But cow's milk often causes enterocolitis, which then leads to slow bleeding, and over time this causes anemia and iron deficiency. It can also cause vomiting and dehydration. Anytime a baby has anemia, it's important to ask the parent if they've been feeding the infant cow's milk. A lot of times what you can get, not necessarily feeding the child milk, but mixing milk into the formula, baby's going to get all the stuff they need with the formula, but the cow's milk protein is still there, and that's going to cause bleeding. So if the answer is yes, the cow's milk should be stopped, and you should replace iron. Appropriate foods for infant include breast milk, infant formula, and age-appropriate baby food. Question 20. A G3P2 mother delivers a post-term baby boy via cesarean section weighing 9 pounds 10 ounces. Pregnancy was complicated by active maternal HSV infection of the birth canal. APGARs were 6 and 8 at 1 and 5 minutes. On delivery room examination, you note tachypnea and expiratory grunting. Saturation improves to 96% with nasal CPAP. Baby is otherwise physically unremarkable. Chest X-ray reveals perihilar streaking and hyperexpansion. Which of the following is the most likely cause of this presentation? A. Intrauterine HSV exposure. B. Post-term delivery. C. Surfactant deficiency. D. Cesarean delivery. Or E. Cystic fibrosis. All right, I'll give you time to pause. And the answer is D. Cesarean delivery. So why is this? What does this baby have? So this baby has got perihilar streaking and expansion, hyperexpansion in the setting of respiratory distress. So you have respiratory distress, right? That's not uncommon. And then you give the baby nasal CPAP, and if the saturation improves, you pretty much know it's lung-related. If it doesn't improve with nasal CPAP, then it's probably heart-related, or you should think along the lines of a cyanotic heart defect. So we know that it's lung-related because it improves with nasal CPAP. We also know that this baby is term. This is not a preterm baby. So that can get rid of hyaline membrane disease / respiratory distress syndrome. There's no meconium, so we can get rid of meconium aspiration syndrome. And that pretty much leads us with the perihilar streaking and hyperexpansion particularly, that pretty much leaves us to retained fetal lung fluid. And that's tremendously common in two scenarios. One, if you have cesarean section where there was no, you would typically need to do artificial rupture of membranes. But if there's no rupture of membranes in the setting of cesarean section, that can be a cause. Or if you have a very short second stage of labor. Those two things are your causes of retained fetal lung fluid. And what generally happens is as the baby is being delivered, the baby will reabsorb that lung fluid, and so it's not there when the baby's born. But if that second stage of labor is too fast or the cesarean section happens, then you can get retained fetal lung fluid that will lead to some respiratory distress. And when you do an X-ray, you'll see perihilar streaking. Sometimes you can see fluid in between the lobar fissures, and then hyperexpansion. So it's the cesarean delivery that is the cause of this presentation. As far as transient tachypnea of the newborn, this is just retained fetal lung fluid, which is otherwise absorbed during labor. It usually follows a short second stage of labor or a cesarean section in which no rupture of membranes has occurred. Diagnosis, just get a chest X-ray. It's pretty easy to see. You'll see fluid along the interlobar fissures, some perihilar streaking. It looks a lot different than respiratory distress of the newborn / hyaline membrane disease. Looks a lot different than meconium aspiration syndrome. So that should help you along with the history. Treatment is nasal CPAP and monitor. This will resolve spontaneously within 12 to 24 hours. The baby will reabsorb that fluid and the lungs will be nice and dry and ready to breathe. I think that's all I got for you. Oh, no, I got a picture. Okay, so here's the fluid. You can see these, well, first you can see the perihilar streaking, kind of, but you can also see these lines here. These lines are fluid in between the fissures of the lungs.